مساء الخير يا بيه. مساء الخير عليكم جميعا. مساء الخير يا دكتور عادل. مساء الخير يا دكتور احمد. مساء الخير يا دكتور عبد الله. ازيك يا وسيم؟ يعني احنا بيسر لنا ان احنا النهارده نبتدي ال 11th ويبينار في الساينتفك ميتنج اكتيفيتي بتاع قسم جراحه العظام في قسم الحضره. وطبعا حاجه بتسرني وبتشرفني ان انا يعني ابقى المدير في السيشن فيها سينيوري قديم واخويا الكبير دكتور احمد البكوري واخويا دكتور وسيم. احنا هنبتدي ان شاء الله بتو lectures دكتور احمد البكوري. اول واحده how I do anterior approach for total hip replacement، وانا واثق ان الناس كلها تسمعها من دكتور احمد.
ألف شكر دكتور أحمد. شكرا دكتور عادل، دكتور عبد الله. يعني أنا مبسوط جدا إن أنا موجود معاكم النهاردة، ويعني حاجة تشرفني جدا إن أنا أبدأ بالبرزنتيشن دي. أنا مش عارف الشير بس موجود، يعني شايفين البرزنتيشن ولا لسه؟
لا مش موجود.
مش
حضرتك
موجود.
ماك
أنا عامل شير
ماك. طب الماك بتبقى موجودة فوق، بيبقى فيه جرين. حضرتك بس تفتح الباوربوينت الاول وبتعمل شير سكرين من اول جديد.
انا عملت يعني انا دلوقتي عملت شير سكرين اوريدي، بس ما وصلتش لسه ما وصلتلكوش. وصلت
كده وصل.
تمام. طيب معلش، دي الثانيه هنبدا بدي.
احمد طمنا عليك الاول. احمد عامل ايه؟
دكتور عادل، ازي حضرتك يا دكتور عادل؟ وحشني
والله.
والله
حبيبي
هو حضرتك ايه؟
الحمد
عاملين
لله.
ايه في الكوفيد ده؟
احنا زي الفل. انتوا اللي عاملين ايه؟
والله احنا كويسين برضه الحمد لله.
شدها لك يا احمد، شدها لك يا حبيبي.
ربنا يكرم حضرتك. انا بس ستوب شير لحظه، اتاكد بس ان السكرين اللي انا حاططها هي المظبوطه. اوكي. تمام. كده واضحه السكرين موجود؟ شير. تمام، شكرا جزيلا. Thank you very much for giving me the opportunity to present this topic. So I'm going to talk about direct anterior approach for a total hip arthroplasty. So my presentation will include, first is to introduce the direct anterior approach through the little bit of anatomy and the surgical approach, surgical procedure itself. And then I'll give a quick case example for DA total hip replacement. Then we need to decide if if direct anterior approach is a muscle sparing approach or not, and why to use DA hip replacement. So we know, all of us, we know that doing hip replacement, it could be through the conventional approaches, whether this is a posterior approach or lateral approach, or more recently, there are some novel approaches, such as direct anterior approach, which is getting more popular in the US and Europe. So the advantage of using DA hip is to allow enhance patients' early postoperative recovery and decrease postoperative pain. So also the anterior approach utilizes an internervous plane between the muscles innervated by the femoral nerve medially and that innervated by the superior gluteal nerve laterally. So we go between sartorius medially and the TFL laterally, and then in the deeper plane, we use the plane between the rectus femoris muscle and the abductors laterally. We try to preserve also the external rotators of the hip, however, sometimes can be sacrificed. We do also hip capsular release in order to facilitate the anterior translation of the femur to allow access to the femoral canal. So traditionally, the patients having a DA hip replacement would be in the supine position. We can use one of those fancy tables. So on the left side, this is the Hanna table. On the right side is a table attachment, which you can attach to your normal operating table. The advantages of using a special table is to decrease the number of assistants. So you can use one assistant, you can have one assistant or no assistants at all. And also it facilitates you using the X-rays, the C-arm around. So it's really easy to get the C-arm on the AP and lateral. Also, it's easier when you do patients with big, high BMI patients. In order, you can use the traction to expose the acetabulum. You can also use hyperextension, excessive external rotation to access the femur in those big patients. You still can use your normal orthopedic table, which has the advantages of having less risk of fractures of the femur. You can also check the leg length bilaterally through the medial malleoli, because the two legs of the patients are not in the boots of the traction table, so it's really easy to check the leg length in a supine position. Also, it allows you to have or to assess the hip stability, especially posteriorly. We might think that having a DA hip replacement can, if you have instability, will be anteriorly, which is common. However, some of the DA hip replacements, you can still have posterior dislocation. So the patient's positioning on the normal table will allow you to bend the hip to 90 degrees and do internal rotation to check for posterior instability. So it's really useful. Either I can do the oblique incision, which is commonly done, which is about 3 fingers below and lateral to the ACES, anterior superior iliac spine, or bikini incision, which is cosmetically better, but also has a little bit of more wound-related complications. Once we perform the skin incision, we go through the subcutaneous fat, protect the lateral cutaneous nerve of the thigh, and then we can expose the TFL fascia. So the TFL, we know that's this TFL fascia because it has a little bit of blue color compared to the white color of the sartorius fascia, which is in the front, and the fascia lata, which is on the lateral side. So this TFL fascia. You can find also small vein, which is coming distally through the perforating the TFL fascia. That's when you know definitely you're through the TFL. Once you get inside the TFL fascia, you go in between the internervous plane, you get this leash of vessels, which are the ascending branches of the lateral circumflex femoral vessels. We can either ligate them, you can use Lega clips, or you can buzz them simply by diathermy. The good thing of buzzing them, it won't take long, but I would suggest you take your time buzzing them, because if they bleed, it will take you longer to control the bleed later on. Once you get through this leash of vessel, you remove the pericapsular fat, you'll find the capsule. Then I would normally perform an inverted T capsulotomy, anterior capsulotomy, where the transverse limb of the T is parallel to the vastus bridge, and the vertical limb of the T in the middle of the neck, parallel to the neck. And then I'll do the capsular releases. Once you do the capsular releases inside the hip joint, you can perform the neck cut. Once the capsule is wide open, I put a retractor at the medial part of the neck, another retractor at the lateral part of the neck, and one retractor on the supraacetabular part. But be careful when you do that, because if that retractor is put superficially, it can put pressure on the femoral nerve. So this is a case example of 26-year-old lady with bilateral AVN and secondary osteoarthritis. She had idiopathic AVN, bilateral Trendelenburg gait, a completely stiff hip. So we performed bilateral total hip replacement DA, but not simultaneously. We did sequential total hip for her. So we started with the left side first, and then we performed DA hip on the right side. So this is the intraoperative video. So this is the medial retractor on the medial neck, a lateral retractor on the lateral neck, and a retractor in the supraacetabular part. So after we did the capsulotomy, I'm checking the lesser troch here, so checking the neck over there, make sure that the leg is internally rotated, and this brings the greater trochanter laterally and protect the greater trochanter from getting injured by the saw. Once we perform the neck cut, make sure that is through the medial side as well. Then we external rotate the leg to create a gap between the femoral neck and the head to allow the insertion of the corkscrew. So here the neck cut is complete. Then we put the corkscrew. You can put it from outside over the neck, from the outer surface of the neck, or in the femoral head itself, like here. Make sure that you get all the osteophytes as well. Sometimes there will be tough adhesions between the femoral head and the capsule. In that case, you might need to run the diathermy to release the femoral head from the capsule. You keep rotating a few times as we do normally in like for hemiarthroplasty, just to completely release the ligamentum. Once that's all through, you just remove the femoral head. Then I would, after this, I would reposition the retractor. So we'll leave the supraacetabular retractor in place, because moving this retractor will put pressure on the femoral nerve. Then I would put the one retractor on the anterior wall, one retractor on the posterior wall, and to expose the acetabulum. After that, we start reaming as we do normally for hip replacement. So we do horizontal reaming to get rid of the medial floor osteophyte. Here, the position might be a little bit awkward if you're using a posterior approach, but this is the direction, this is the horizontal way of doing the, or getting rid of the osteophyte. Then once we got rid of this osteophyte, we'll incline the reamer handle more towards the leg of the patient to get about inclination angle or abduction angle about 40 degrees. Make sure that the virgin is in the right place. And then we'll just do sequential reaming. Once we're happy with the reamers, I use normally trial acetabular component with fluoroscopy. Check number one, position of the trial. If it's the inclination about 35 to 40 degrees, a virgin about 20 degrees, then if that looks okay, then I'll just put the final acetabular component. Sometimes I add additional screw for extra stability. Once we're happy with the acetabular component position, then we start to prep the femur. Before we prep the femur, in the anterior approach, it's really important to perform a thorough capsular release. So when we do the capsular release, we start to release the inferior capsule from the calca, and also to release the superior lateral capsule from the superior part of the minimus tendon. So normally there is adhesions here between the minimus as well as the lateral capsule. I run the diathermy to release that, and then release the superior part of the capsule. Performing the capsular release is really important in order to elevate the femur out of the wound. Then you can actually get the right direction for your instrumentation, protect your femur from perforation, because it's really easy for anterior approach. If you don't get the right angle, your stem will end into varus, as well as you can perform or perforate the femur. Once we've done with the release of the capsule, I put a retractor, one retractor medial, one retractor lateral over the greater trochanter, and one retractor superiorly over the tip of the greater trochanter between the capsule and the minimus. The leg position will be hyperextended. So if we're using a normal table, we'll just break the table a little bit to hyperextend the leg, abducted and externally rotated to expose the femur. So this is the same case here. So the leg is abducted, externally rotated, hyperextended. So the operative leg, the right leg, is under the left leg to keep it abducted. This is the retractors in position. and then I use a burr to open the lateral part or to lateralize the entry point. Then I use blunt instrument, whether it's a canal finder or a curved artery clip or a cocker, to find the direction of the canal. Once you find the direction of the canal and you have the right angle to approach the canal, the rest will be much easier. So you get, this is, sometimes I use this rat tail instrument to just take away some of the cancellous bone over the lateral cortex to make sure that the stem later on will be in the center of the canal. After we lateralized, we opened the canal. I just normally do what we do normally through posterior approach with sequential broaching of the femur. So we check the version of the brooch, and we start with the smaller size as normal and go bigger till we get the right size in. Once we get the right size brooch in, we'll perform trial and we'll get intraoperative fluoroscopy to assess for stem size, stem alignment, whether it's varus, valgus, or central, and also leg length and offset. So just make sure that you don't change the, as we know, don't change the RAS position in the canal, otherwise you can lose the virgin. So this is an example of intraoperative X-ray we do is, I use this metal tool, any long metal tool, to recreate the transischial line, which is should be passing through the lesser trochanter on the other side and lesser trochanter on the ipsilateral side. And we can see here, this is leg a little bit longer. So we know from this trial that we need to bury the trial a little bit in to get the correct leg length, as well as we know that this is probably the good size trial in terms of filling the canal, and the alignment is good too. After we inserted the actual stem, we're happy. We just impact the femoral head. We reduce the femoral head into the acetabulum. The assistant will put some traction on the leg. The surgeons will put the pressure on the femoral head using a pusher, and with internal rotation force, the femoral head will get into the canal. This is an intraoperative X-ray picture after the implantation, and this is the post-operative X-ray for the same patient. So the question we need to ask ourselves, so the DA is advertised as its muscle-sparing approach, and it is to a certain extent, but is it a totally muscle-sparing approach or not? We know that we're going in between the muscles. We're preventing taking off any of the muscles, which we do, and the posterior approach. We don't go through gluteus maximus. We don't go through the IT band. So that's why we thought we can check the short external rotators position tendon. So we did this study, which is an MRI study, which included patients going for a total hip replacement through anterior approach. We performed MRI preoperatively and MRI at 3 months' time to see how much of the damage has happened to the short external rotators. So all patients had MRI preoperatively 4 weeks before surgery. Then they had the operation. At the time of the surgery, the surgeons who did the operation reported the releases of the tendon, how much releases they performed to that tendon. So post-operatively, all patients were full weight bearing. We recorded the analgesia, and we recorded also the length of stay in hospital. All patients had MRI at 3 months, reported by 2 MSK radiologists, and if the 2 radiologists had different opinion, then this was resolved by a consensus. So this included 25 patients. All patients had primary osteoarthritis. We didn't include any patients with AVN or inflammatory arthropathy. Mostly was left side males, 65 years on average, and the average BMI was 28. So the surgeons reported only 2 releases of the conjoint tendon intraoperatively, no releases in piriformis, and no releases of obturator externus. However, the MRI showed that obturator internus was damaged in 23 out of 25 patients. Piriformis was damaged in 22 out of 25 patients, and obturator externus was damaged in 1 patient, and that all were statistically significant. So the analysis didn't show that age or sex or BMI affected the occurrence of the tears. So this is an example. The top row is the preoperative MRI for one of the participants in the trial. So the white arrow here that you can see, this is the obturator internus tendon or conjoint tendon. This is the obturator externus tendon going posteriorly. This is the piriformis. This is all the preoperative MRI, and this is the postoperative MRI scans, where here there is the tendon, the obturator internus tendon and conjoint tendon is replaced by grayish scar tissue, which is not attached anymore. The obturator externus is still intact, and the piriformis tendon is not there. It's just grayish scar tissue, so that was damaged. So that shows that although the surgeon didn't deliberately release the shorter external rotators, they have been damaged through the direct anterior approach. So we think that direct anterior approach, although it's really good in terms of preserving other muscles like TFL, abductors, and sartorius, and IT band, the short external rotators are commonly injured after total hip replacement, even if they are not deliberately released. Those patients included in the trial, they did really well. They went home in the same day or the day after. They didn't have much pain. So they were normal routine DA patients. So we think that DA or the results of the DA is not related only to this muscle sparing approach, but also to the preservation of the IT band. So maybe because we preserve the IT band, that's why these patients are doing so well early postoperatively. So the last question is why to use direct anterior approach, total hip replacement. We know from literature, these patients are doing well in the first few weeks. They're much better than posterior approach and lateral approach in the first few weeks. They don't use assistive devices for long compared to posterior approach. However, at 6 weeks, we know that direct anterior approach is comparable to posterior approach. So there's no difference in terms of rehab at 6 weeks, but it's early on in the first 2 to 3 weeks, direct anterior approach hip patients are doing better. So definitely less postoperative pain with DA compared to other approaches. And then hence from that is the hospital stay will be short. So if you think you would like to do a day case total hip replacement, so probably the direct anterior approach would be your workhorse of doing this. It's really good for that. It's easier to get intraoperative X-ray when you have the patient in supine position. That can optimize your component position, whether it's a acetabular component or femoral component. However, we know that even if you're, when we do posterior approach or lateral approach, if the X-ray is not 100%, the cup is a little bit open, cup a little bit closed, a little bit not very anteverted. We know that the stem is a little bit inverse. These all tiny things don't translate into clinical significance for our patient scores. So we're not sure if we're getting a better X-ray will be translated to a better clinical outcome or not. Probably not. Supine position is much easier to assess leg length, so it's really unlikely for DA patients to have a really leg length discrepancy postoperatively. And some papers were reporting less dislocation rate with DA. However, I'm not sure if that's true. We still can see patients with dislocations after direct anterior approach, and it can happen. Anterior dislocation can happen, posterior dislocation can happen. So at the moment, there are a few RCT or randomized controlled trials are comparing posterior approach to direct anterior approach, and we'll know if hopefully in the next year or two whether the direct anterior approach has the advantage of having less risk of dislocation or not. But so far, there is no evidence that DA hip has less risk of dislocation. In terms of disadvantages, definitely many patients will have a numbness on the lateral part of the thigh due to injury of the lateral cutaneous nerve. Interoperative fractures, it's more common in DA compared to posterior approach. However, they are still rare. With the femoral fractures, if you're using traction table, you might find that putting more force on the femur and you're getting femoral fracture. With conventional orthopedic table, it's less likely for you to get femoral fractures. So just be careful when you pick up your patients to start with. Big patients are always challenging as regard to femoral exposure. It's difficult. We know that DA is not completely muscle sparing approach, and even if we don't release the short external rotators, they can get damaged after. Probably the wound-related complications are more frequent with DA compared to posterior approach. However, with meticulous closure, make sure that you also close the dead space in the subcutaneous tissue and keep the wound sealed, then the complications would be much less. And femoral nerve neuropraxia, this can happen, although rare, is less than 5%, but probably more common compared to other approaches, but they are mostly self-limiting and they resolve spontaneously within a few weeks normally. So to take home message, DA is good in terms of post-operative rehab. Patients recover quicker, they leave the hospital early, you can do day cases, they have less pain. We know that DA is not completely a muscle-sparing approach, and then you might damage short external rotators. If you try to adopt DA approach, just be careful, just start with selective approach, do a DA in simple, straightforward cases, avoid big patients, avoid patients with weird anatomy, like patients with protrusio. It's difficult to expose the neck and to do the femoral cut. It will be difficult during DA. Also, patients with low offset as well, it will be difficult to do. Avoid doing DA hip to start with on osteoporotic patients. Otherwise, you can get femoral fractures. I think the key point is also pre-operative patients counseling regarding the advantages they can get from this approach and the risks associated with it. And thank you very much for your attention.
شكرا أحمد، والله التوك جميل.
ثانك يو دكتور احمد على التوك الانفايتنج ديت. احنا لحد دلوقتي ما عندناش كويستشنز، هناخد الدسكشن كلها بعد بعد الليكشر الثانيه ان شاء الله.
طيب تمام، شكرا جزيلا. الشير السكرين واضحة؟
تمام.
طيب هنتنقل بقى من الارثروبلاستي وندخل في حاجة في الهيب preservation يعني أو management of pre-arthritic condition. So thank you very much for inviting me to do this talk. This talk would be about the use of hip arthroscopy for management of hip disorders. So hip arthroscopy is not a new tool. So that was almost 90 years ago, or more than that, is by Mike Berman, who from New York City, who performed the first hip arthroscopy. And those are the pictures he has taken on the femoral neck. So it's not a new thing, but probably what we do with hip arthroscopy is newer compared to what they used to do in the past. So Professor Ganz in 1999 and then in 2001, they described the femoroacetabular impingement in Switzerland, and this actually had made the hip arthroscopy and labeled and hip arthroscopy indications are common. With the advantages of the use of arthroscopic cam removal with the new technique of labor repair and early postoperative rehab, this actually caused a significant improvement of the clinical outcome of patients having hip arthroscopy. So in terms of indications of hip arthroscopy, whether it's intra-articular pathology or there's extra-articular indications, we can perform hip arthroscopy for. So intra-articular indications, most commonly is femoroacetabular impingement. We can remove the cam, we can treat the pincer, we can manage the labral tear, we can manage some of the condylar lesions through hip arthroscopy. In terms of other things we can do, we can release the psoas tendon if it's inflamed or if it's causing psoas impingement. We can treat tears in traumatic labral tears in athletes, which can happen. We can remove loose bodies. We can perform synovectomy. We can do lots of things with hip arthroscopy. In terms of extra-articular indications, the IT band could be released endoscopically. We can repair the abductor tendon. We can release the sciatic nerve and perform a release for ischiofemoral impingement if required. This is a setup for hip arthroscopy. Routinely, we use C-arm I use C-arm in all cases. I use a supine position and in traction post, and with the monitor. I use two key tables. I use one assistant. I have one scrub nurse and some other tools. So if you're using hip arthroscopy, make sure that you use a well-padded perineal post just to protect the pudendal nerve. Make sure that the post is lateralized to make the vector of the forces laterally, and then this will allow distraction of the femoral head out of the acetabulum. These are the tools we use normally, lots of long instruments and with bendy instruments to get into the tight space of the hip. In terms of portals, we use normally routinely anterolateral portal to start with its safest portals in terms of safer for the labrum. So we go about 2 centimeters above the anterior part of the anterior greater trochanter line, and 2 centimeters in the front to do the anterolateral portal. Then we can use combination of portals. You can use anterior portal or proximal portal or posterolateral portal. These are the portals. Anterolateral portal, that's the workhorse of hip arthroscopy. Anterior portal is about lateral to the ASIS line here, and the mid-anterior portal is more distal and a little bit more lateral compared to the anterior portal. This is an intraoperative X-ray, so we get distraction about 1.5 centimeters to 2 centimeters of the joint line. We use nitinol wire to make sure that we are not in the labrum with the X-ray. So the wire is just above the femoral head, so it's not scuffing the femoral head, and it's away from the labrum as well. This is a diagrammatic picture. So this is the where we put your a scope and your working portal. This is the picture you see from the lateral portal. So your viewing is lateral portal, and this is the anterior portal. You look for this triangle, which is the synovium here, the labrum on the left, and the femoral head, and that's your safe spot to put your mid-anterior or anterior portal in. So this is the same here. So this is endoscopic view. This is a right hip distracted. So this femoral head, acetabulum, labrum, triangle in between, and you put the wire and you establish your mid-anterior portal or anterior portal under vision. Once you establish your portal, you do a little bit of capsulotomy to make sure that you navigate your tools safely inside the hip without putting much pressure on the articular surface and much damage on the chondral surface as well. I don't normally do interportal capsulotomy routinely, but sometimes you need to connect the portals if required. So this is just a quick video for interportal capsulotomy. So I'm looking from the anterolateral portal, working from the mid-anterior portal. Then I'm just removing, this is the labrum here. So this is a left hip, so the labrum, femoral head. We're just removing all the tissue and the capsule towards the anterolateral portal. So performing interportal capsulotomy. Once I perform the interportal capsulotomy or widen the capsulotomy, which I just swap the portals. So I'm looking here from the anterior portal, looking at the anterolateral portal to check if we're going through the labrum or not. Once we establish that, we can actually widen the capsule here to ensure safe navigation of the camera inside the hip. We look into a few compartments. We look at the central compartment first. I look also in the peripheral acetabular compartment, then peripheral femoral compartment. If required, I can go through peritrochanteric space. So in terms of structures I assess with central compartment, I look for at the labrum, acetabular articular surface, femoral articular surface, ligamentum, look for loose bodies, and look for the synovium if it's inflamed or not. Start my diagnostic tool looking at the labrum, just put some pressure on the labrum, make sure this is not torn. This is the right hip, this is femoral head, this is the acetabulum. Then look at the femoral head, look at the acetabulum chondral surface, look if there is any degeneration at the acetabulum too, and look at the ligamentum teres. So it's left hip, femoral head here, acetabular fossa there, and this is a ligamentum teres which is partially torn. So this is an example. So it's a right hip, which is femoral head here, chondral surface there, a big labral tear with big labral with chondral flap. So I'm just, you can see that the whole labrum is torn and is flipped over. Then I'll look at the peripheral compartment. I look at the supraacetabular recess, assess the pincer, assess if there is any os acetabulae lesion, and assess for subspine impingement. So this is how I used to do the clearance of the supraacetabular space. This is the above the labrum, so the labrum is there, and I'm just working above the labrum to expose all the bone here. So just remove all the soft tissue, which is mainly capsule remnant there, to see if there's any os acetabulae or if there is any subspine lesion. This bit can take a bit of time. It can take 5 to 10 minutes to clear all the soft tissue as well sometimes. Once it's clear, check for any bony prominence over the acetabulum, either subspine or os acetabulae. Then here I'm just taking off the capsule around the clear-cut cannula, and you can see here this is like a bony prominence there, so that can cause subspine impingement. So what I normally use is 5-5 bear, or sometimes 4-5, but normally 5-5 bear, and just bear that way with the bear. So this is the labrum here. This is above the acetabulum at the edge. Just use the bear to make sure that this is all gone, to make it nice and concave. If there is a label tear, we most likely to repair it. It's very unlikely to debride it. I normally use a knotless anchor with a loop stitch, like around the labrum. Sometimes I use also a mattress stitch if the labrum is so big. This is a quite useful tool. You can use this nanopasser. It's really easy to repair the labrum using this. You just do a loop stitch, like a lasso type of stitch around the labrum. Once I pass the stitch around the labrum, we normally use knotless anchor, which is much easier than the knotted anchor. Then I just drill for the anchor and the acetabulum part. Make sure that the angle is quite far from the chondral injury, because it's really easy to get through the articular cartilage. We can check sometimes with X-ray, make sure that we are away from the chondral surface. Once we establish this, we check with the wire, make sure it's very if there is an end point there, then we just use the knotless anchor through the stitch. There are a few types of knotless anchors, as we all know, but some of them allows you to tension the suture after you put the whole anchor in. Others don't allow you to do that. But this is, I think, that was pop lock anchor. So you can't tension after you put. So you make sure that you will get enough tension after you put your anchor in. So another patient with labral tear with also damaged or red inflamed labrum, which is probably related to pincer lesion. So just do 2 circumferential stitches on that, and with these new instruments, with like Nanopass or Acupass Direct, is quite easy to perform the labral repair. And then I check if we need to have a very good tension over the labrum, not over tight, not lax. So check the tension around. We're using a hook. When we get the right tension, we can release the traction, and then check for impingement. We do use intra-operative dynamic impingement test to check if there's any tension over the labrum. So I flex the hip up to 90 degrees at least, do internal rotation, and see how much impingement you can achieve. Then you can address the cam. If you have articular cartilage damage, so you can either debride it, or you do microfracture, or you can use fiber and glue. You can use also autologous chondrocyte implantation or stem cell therapy. However, they are still under research, and they are not as successful as the knee so far. So no one using them in clinical practice unless it's a research study at the moment. So this is a really big flap here. So and it was really worn. So I couldn't repair that back, so I debrided that. If you have a flap like this, you might do microfracture, which is about 60% success. You can use an multiple. You just do multiple holes there, just to, when you see the fat, you know that you reach the subcondylar bone, and then you can actually protect the patient's weight bearing a little bit. I use sometimes fibrin glue if the flap is contained. So this is a patient with the labral tear, and you can see the wave sign when we press on the labrum. You can see the articular cartilage is moving like a wave. So in those patients, after you repair the labrum, we can use the axis, the axis needle we use to get into the hip. We put this behind the labrum, behind the subcondylar, between the subcondylar and the cartilage flap, and we can inject fibrin glue in there, which I'm doing at the moment in this case. So injecting fibrin glue there. Once the fibrin glue is injected, we're happy. Then we can release the traction. This will make the femoral head to go back into the acetabulum, press on the condylar flap. Once you press on the condylar flap, once it presses on the condylar flap, this will make the condylar flap sticks to the subcondylar bone. They are injecting, but it's going everywhere anyway. And then you just release the traction, it will stick down. So in terms of peripheral compartment work, we can we can resect the cam lesion, we can remove loose bodies, we can remove impingement cysts. If we want to go to the cam, we can do a distal extension to the capsulotomy. Once we get to the cam, I start normally removing the anterior cam here. So the viewing portal is the anterolateral portal, the working portal is the mid-anterior portal, and just take the, this is 4mm bare, just to remove the cam anteriorly. We make sure that the cam is removed all the way medial to lateral. Once we resect all the anterior cam, I swap portals. So my viewing portal would be the anterior portal, my working portal would be the anterolateral portal, and I remove the lateral cam too. So here still working on the anterior part of the cam, make sure that we get nice like a cancellous bone. Make sure that after this we'll do a dynamic impingement test to make sure that we removed enough of bone. This is the labor repair on the chart. We removed the whole, most of the anterior cam. We just go a little bit further, go a little bit laterally, and distally as well. Once we get the anterior cam removed, then I swap portals, work from the anterolateral portal, view from the anterior portal, and then take the lateral cam off. We know I checked also the level of resection with X-ray anyway, fluoroscopy. Sometimes if you have an impingement cyst, you get, you need to decompress it. So this is a probably big impingement cyst here. It's about bigger than the burr. So this 4mm burr, so it's probably 6 or 7mm impingement cyst. Once we decompress it, hopefully it will heal. So just decompress the floor. If you have a big impingement cyst, you might need to restrict the patient's weight bearing a little bit, like to do partial weight bearing for a couple of weeks or so. Then finally, we do the dynamic impingement test. So flexion of the hip to at least 90 degrees, internal and external rotation, and you can see, you should see a clear space between the labrum or the repaired labrum and the femoral head, and that means that hopefully this patient won't have the same problem of impingement later. You can repair the capsule if you perform a bigger, wider capsulotomy. So like this case, so we did a capsule. So you need to have a curved tool, like 70-degree slingshot. Here we just repair the two flaps together with the slingshot. You can use the hip arthroscopy for peritracheal space. So like this case, so if you have a tight IT band or flicking IT band syndrome or trochanteric bursitis, you can just do the release endoscopically there. You can look at the abductors as well. That's from outside in. You can do inside out or outside in. Make sure it's complete release as well. In terms of evidence for hip arthroscopy, so in cases of femoroacetabular impingement, we use hip arthroscopy quite often. So there were 2 randomized controlled trials. One is called the FATE at the University of Oxford and FASHION trial from Warwick, and both actually concluded that hip arthroscopy is very good in management of femoroacetabular impingement. So patients were randomized to physiotherapy versus hip arthroscopy. Both hip arthroscopy and physiotherapy did improve the patient's symptoms. However, the patient's improvement after hip arthroscopy was better. We can use hip arthroscopy in cases of borderline dysplasia. Yes, we can, but we know that is not the ideal treatment for those patients. Definitely moderate or severe dysplasia is better to avoid using hip arthroscopy for them. So we published this work a couple of years ago, and we know that patients with severe dysplasia, they don't do well with hip arthroscopy, so you probably do periacetabular osteotomy type of to treat them. Moderate dysplasia, probably you need to do also periacetabular osteotomy or something like this, but definitely borderline dysplasia, we don't know yet what is the best treatment for those, but you can use still hip arthroscopy to manage those patients. But be careful when you do that. We need to repair the labrum, not to debride it, because that destabilizes their hip, as well as if we perform big capsulotomy, we need to repair it as well. So thank you very much for your attention. Thank you. شكرا جزيلا.
شكرا دكتور أحمد على المحاضرة الجميلة دي. هو في معنا سؤال من المحاضرة الأولانية about the injury to the short external rotators. هل كان في الاستادي اللي انتم عملتوها كان في clinical assessment to the patient to see whether those patients have been worse clinically, or was it only radiological assessment of the short external rotator injury؟
لا احنا لا اتفضل.
انا كان السؤال الثاني بتاعي، هل ده ما يعني هو ممكن الاكسبلانيشن ان ده ما اثرش على الديسلوكيشن ريت، ان كان الاليوتيبال باند انتكت ما حصلوش انجري، فعشان كده ما فيش فرق في الديسلوكيشن ريت ما بين البوستيريور والانتيريور، بالرغم ان انتم ما عملتوش، يعني انا اعتقد ان انتم ما عملتوش ريبير لشورت اكسترنال روتيتورز، لان
احنا
اتفضل.
هو سؤال كويس جدا. هو بص، اللي بالنسبه للستادي دي احنا عملنا لها طبعا كلينيكال اسسمنت، يعني كل الناس عملنا لهم برومز، ما فيش حاله فيهم حصل لها ديسلوكيشن، ما فيش حاله حصل لها كومبليكيشن، هم 25 كيسز يعني. بس احنا ما عملناش كومباريتيف، يعني قصدي ما كانش عندنا كومباريتيف ارم، هي كانت بس كل العيانين دول دي اي بس. بالنسبه للشق الثاني لل اي تي باند، الاي تي باند طبعا بيكسبلين ان العيانين دول preserved اي تي باند هم عيانين دول doing well anyway، يعني عندهم اي مشاكل خالص. النقطه الثانيه في السؤال، انت كنت بتسال على
الديسلوكيشن ريت، يعني هو الديسلوكيشن ريت تفسيرك ليه موضوع الاليوتيبيال باند، ولا هو شايف ان الاليوتيبيال باند بس ليه علاقه بالكلينيكال اوتكم؟
احنا ما نقدرش نقول ان الديسلوكيشن ريت اقل لغايه دلوقتي في الحالات الدي اي. في بيبرز مطلعه ديسلوكيشن ريت اقل، بس لسه لغايه دلوقتي في بيبرز مطلعه ان في ديسلوكيشن بيحصل لهم انتير ديسلوكيشن، بيحصل لهم بوستير ديسلوكيشن. فلغايه دلوقتي في انا aware of 2 على الاقل ار سي تيز دلوقتي randomized control trials لسه بيتعملوا شغالين فيهم بيقارنوا posterior approach بالdirect anterior approach، وهم دول اللي هيقدروا يقولوا فعلا هل الdirect anterior approach ده معاه dislocation rate اقل ولا لا.
السؤال الثاني بقى بالنسبه للانجري اوف لاترال كيتينيس نيرف اللي بتحصل مع الدايركت انتيريور ابروتش. احنا عارفين من الهيب ارثروسكوبي ان هو لما بيحصل معايا احنا يعني ممكن بيبقى غالبا تمبرري ما بيطولش، وليه يعني ان هو بيبقى حاجه لونج تيرم. مع الدايركت انتيريور ابروتش بيبقى حاجه برضه تمبرري ولا ساعات بيطول؟
لا هو قريب من الهايبارثروسكوبي. انا عندي في الهايبارثروسكوبي بصراحه حالات بتطول يعني لونج تيرم، فقصدي هو الهايبارثروسكوبي اللي بيحصل ان هو بيقل السايز. يعني الاول بيقول لك ان هو مثلا بيبقى مثلا كل الثاي، بعد كده بيقل، وبعد كده بيبقى في نظام باتش حوالين البورتلز. ونفس الكلام في الانتيريور ابروتش، بيفضل يقول لك ان اللاتر ثاي كلها نمنس، وبعد كده بيقل يبقى حوالين الانسجن. بس يعني هو حاجه لونج تيرم، بس العيانين مش بيتضايقوا منها، زي مثلا التوتال ني لما بتعمل توتال
يبقى
ني
في نمبر اريا. تمام
الانفرابيتيلر برانش نفس الكلام. فللاسف ما لهاش حل. اهم حاجه ما تقطعش المين ترانك عشان ما يجيلهمش نيوروما، لان هي دي المشكله. لو جالهم نيوروما هتبقى مشكله، بس النمنس عاده ما بيضايقهمش.
شكرا دكتور احمد على البرزنتيشن اللطيفه دي.
شكرا
احنا
جدا.
دلوقتي الله يخليك، احنا دلوقتي معانا ايوه يا فندم.
انا معاك عبد الله حماد، حاولت اسال.
اتفضل يا بيه.
يا دكتور
معاك. اتفضل يا بيه اتفضل.
دلوقتي الايفيدنس بتاع البريزرفيشن اوف اليوتيبيال باند دوت، ده حاجه يعني بروفد بحاجه ايفيدنس؟
لا،
لان لو كده احنا ممكن نريبريدوس الكلام ده للدايركت سوبيريور ابروتش اللي هو
لا. صح، ده سؤال ممتاز جدا. وما فيش ايفيدنس، بس هو اللي بيحصل ايه، لان انت دلوقتي عندك دايركت سوبيريور ابروتش زي ما الدكتور عبد الله قال. الدايركت سوبيريور ابروتش انت مش بتقطع الاي تي باند، والعيانين في الدايركت سوبيريور ابروتش البين بتاعهم قليل برضه، والهوسبيتال ستاي بتاعهم قليل برضه، وبتقطع شورت اكسترنال روتيتورز. في الدي اي انت برضو غصب عنك واضح انك بتقطع الشورت اكسترنال روتيتورز، حتى لو انت ما عملتهمش ريليس انتنشن. ليه احنا عملنا الام ار اي لقيناهم مقطوعين مع اننا ما عملنا لهمش ريليس، غالبا من الراسبنج يعني. فاحنا بيزد على الكلام الدكتور عبد الله ان دايركت سبير ابروتش بيشنت برضه دوينج ويل، احنا بنسبيكيوليت ان ممكن يكون هو الاي تي باند هو ده الفاكتور الموجود، انما ما فيش حاجه تثبت 100% ان الاي تي باند هو ده السبب ان العيانين دول بيتحركوا بدري وبياخدوا الانالجيزيا بتاعتهم اقل والبين بتاعهم اقل.
اوكي ثانك يو.
تحت امرك.
شكرا دكتور احمد. احنا دلوقتي شكرا لشركة لابتس على البرزنتيشن اللطيفة بتاعتهم دي. ودلوقتي هبتدي أنا في البرزنتيشن إن شاء الله، وبعد كده هيبقى في البرزنتيشن لوسيم بإذن الله. احنا النهارده البرزنتيشن هتبقى عن الفيمورو استابلر امبنجمنت، ان ازاي نعمل لها ايدنتيفيكيشن وامتى نعالجها ونعالجها ازاي. تمام. هنبتدي اول حاجه بالديفينيشن. اكيد حاجه زي كده محتاجين نعمل ايه ليها ديفينيشن. الفيمورو استابلر امبنجمنت is a clinical pathologic syndrome due to mechanical conflict between the moving parts of the hip joint within the physiological range of movement producing and labral and or chondral damage. هي مش راديولوجيكال سندروم، فمش كل عيان عنده راديولوجي بتاع الفيمورو استابلر امبنجمنت سواء الكام او البنسر ده عنده بتاع ده فاي. فالفاي هي كلينيكال سندروم. التو تايبس بتوع التو مين تايبس اللي كانوا ديسكرايبد بجانز اللي هم الكام تايب، اللي هو احنا زي ما احنا عارفين هيبقى فيه انكريزد بون ات هيد نيك جونكشن، ده مع الموفمنت هيعمل ستريس على الانتيرو سوبيريور ليبرم وممكن يعمل كوندرال ديلامينيشن زي ما شفنا في الفيديوهات بتاع الدكتور احمد، وفي الوقت نفسه ممكن يعمل ليبرال تير. تمام. البنسر تايب هو عباره عن اكسس كفرج للفيمورال هيد باي ذا اسيتابلم، فبالتالي مع الموفمنت هيحصل كونفليكت ما بين الفيمورال هيد والليبرم، فدي ممكن ينتج عنها ليبرال تير، وفي الوقت نفسه هينتج عنها حاجه مهمه جدا اسمها كاونتر كوليجن، ان هو بيحصل بوسترو سوبيريور ليبرال اند اور كوندرال دامج زي ما هيبان في الفيديو دلوقتي. ممكن مع الريبيتيشن هيحصل كونفليكت هنا، وبعد كده هيحصل ايه؟ الكاونتر كو ليجن بوستيرو سوبيرو. طب هو الدامج ده اللي هيحصل هيبقى متوقف على ايه؟ متوقف على 3 حاجات، على الديجري اوف بروبلم، على الريت اوف لودنج، العيان ده وزنه ازاي وبيعمل اكتيفيتي شكلها ايه، والديوريشن اللي فيها المشكله دي موجوده. خلاص. واحد من الناس اللي فهموا الامبورتنس اوف تايم او الديوريشن الراجل اللي في الصوره دي، واعتقد ناس كتير اتفرجوا على الفيلم وهيفهموا ان التايم مع اللود لفتره طويله ممكن ينتج عنه مشاكل كتير. الاوريجينال ثيوري ابتدت من البيبر اللي نشرها جانز في 2003. هو قال ان هو بعد ما عمل سيرجيكال هيب ديسلوكيشن للعيانين كتير جدا شاف فيه دامج باترن، وقال ان الدايناميك اوريجن بتاع الدامج ده جاي من الفيمورال اسابدل امبنجمنت، ووصف التو تايبس اللي احنا شايفين لسه شايفين الفيديوهات بتاعتهم دلوقتي. طب احنا هنعرف العيان ده عنده ازاي؟ دي مشكله ساعات بتقابل ناس كتير. يعني في البراكتس بتاعتي هنا بشوف حالات كتير كانوا ميس دايجنوزد، سواء كانوا عندهم لامبر بروبلم او عندهم ني بروبلم، هو في الاساس المشكله جوه الهيب. خلاص. او لو العيان جاي اصلا هو بيقول انا عندي هيب بين، ساعات المشكله بتبقى ميس دايجنوزد لفترات طويله، والمشكله بتبقى ايه؟ تخش ساعات في كرونيسيتي بسبب ايه؟ الميس دايجنوز. الدايجنوز بتاع اليانج ادلت هيب بين هو حاجه ساعات بتبقى كومبلكس عشان في مالتيبل باثولوجي، وفي ساعات بيبقى ريفيرال باثوي باترن بتخلي في ساعات مش كلاسيك برزنتيشن للبروبلم. بنبتدي عادة بأي عيان عشان نعمله دايجنوز بالهيستوري، لازم العيان يبقى عنده سيجنفيكانت بين زي ما اتفقنا، ما ينفعش يبقى عيان عنده مورفولوجي فأقول عليه كويس، لازم العيان يبقى عنده سيجنفيكانت بين. عيان كلاسيك هيمسك الحوض بتاعه كده، ده كلاسيك سي بيرت ساين، كلاسيك ساين أو سي ساين أو بيرت ساين، دي معناها إن العيان عنده مشكلة جوه الجروث. خلاص. العيان ممكن يكون عنده ميكانيكال سيمتومز كليكنج ده ليه 3 حاجات ممكن يجي منها. ممكن يكون عنده ليبرال تير، ساعتها بيبقى صوت واطي قوي، العيان بيعرف يريبروديوس الموفمنت اللي بتطلع الليبرال تير، وانت ممكن تحسها وانت بتعمل اكزامينشن. انترنال لو هي الايوسوس بتفليب على الايليوبكتينال ايمنس، واكسترنال لو هو الايليوتيبيال باند. في عندنا البوسيبل بوزيشن، نعرف العيان ايه الاكتيفيتي اللي هو بيعمله، هل كان في تروما او حاجه، وفي ايه الفانكشن ريكويرمنتس اللي هو عايز يعملها بعد ما الهدف بتاعه من التريتمنت يعني. بالنسبه للاكزامينيشن، اول حاجه احنا طبعا بالاكزام نشوف الرينج اوف موفمنت، بنلاقي فيه ريديوس ديفليكشن وانترنال روتيشن، خصوصا الانترنال روتيشن عند 90 ديجريز، ده هي هاي بوزيتيف بريدكتيف فاليو. ده لو احنا عملناها كومباريزون مع الاذر سايد، اللو رول تيست والعين فارد رجليه ليه لو بوزيتيف بريدكتيف فاليو. الكلاسيك امبنجمنت تيست زي ما باين في الصوره ان احنا نعمل فليكشن ادكشن انترنال روتيشن، ليه هاي سنسيتيفيتي بس لو سبيسيفيستي، يعني ممكن يبقى بوزيتيف في حاجات ثانيه غير الفاي او الليبرال تيب. ولو عمل موديفيكيشن للتيست باي ادنج اكزيال كومبريشن تو ذا ني، ستيل بور بوزيتيف بريدكتيف فاليو. الفيبر تيست ده من التيست مهمه جدا، فليكشن ابدكشن اكسترنال روتيشن، لان اللوكيشن اوف بين بروديوسد بيديترماين ذا انتربريتيشن، بمعنى ان لو البين ورا عند الباك ورا ممكن يبقى ساكرويلايتس، بس لو البين عند الهيب عند البوستولاترال بارت اوف ذا هيب ممكن يبقى في بوسترو سوبيريور ليبرال دامج. دايناميك تيست ان احنا بنعمل سيركمدكشن للهيب وبنشوف واحنا طبعا عاملين فليكشن وانترنال روتيشن. فليكشن، فالفليكشن مع السيركمدكشن ده بيقولوا من الانترنال للاكسترنال روتيشن بيدينا السايت او اللوكيشن اللي العيان فيه عنده موست بروبلم. ممكن يبقى مش لازم يبقى ايه دايركت انتيريور، الكلاسيك امبنجمنت تيست بيكمبرس الفيمورال نيك اجينست ذا انتيريور، الموست انتيريور بارت بتاع ايه بتاع
احمد في ناس سمة ما بتعرفش تتكلم عربي يا احمد والنبي، حاول تكون كل انجلش والنبي عشان
I'm sorry. So for the dynamic test we are doing flexion and circumduction going from internal to external rotation. So this will press the femoral neck against the circumference of the labrum, so it will reproduce the site of the patient problem. The classic impingement test just compresses the femoral neck against the most anterior part of the labrum, so that it doesn't, it may miss some of the labral injury. The posterior limb test with the Gans apprehension test, the patient comes to the edge of the bed with the lower limb hanging in extension, abduction and external rotation. And the last test, which I like so much because it helps me in my clinical practice, which is the resisted statically grazing test. So the patient lifts his hand like about 30 or 40 degrees, and he is trying to push the examiner's hand up. This pain is very specific. So when the patient has this test positive, usually he has a ribral tear. So when we are going to investigations, why we don't depend on X-ray in diagnosis of FI? Because the appearance on the X-ray depend on several factors, including the projection, the film tube distance, the patient film distance, the centering and direction of X-ray, and the pelvic orientation. And we can't guarantee to standardize each of these measures of these variables with each examination of the patient. So we may have misdiagnosis of FI, or we falsely don't do this diagnosis. So this is the same patient with the pelvis-centered X-ray and the pelvis-low-centered X-ray, and here we see clear signs of acetabular retroversion, which is absent in the other slide, in the other view of the same patient at the same time. So we don't depend on the X-ray for diagnosis of FI, we depend on CT. CT has the advantage of more precise characterization of the subtle bony abnormality of FI. Is usually a subtle bony abnormality. It's not a huge bony abnormality, like dysplasia, which is evident in X-rays anyway. But this subtle bony abnormality will be more precisely characterized on the CT. The CT, we can measure all the measurements we do on the X-ray. We can measure the neck anteversion, we can measure the alpha angle, we can measure the acetabular retroversion in different levels to see if there is whole acetabular retroversion or focal cranial retroversion, as well as it has a lower cost rather than repeating the X-rays with relatively short scanning time and new lower radiation dose scanning techniques. Going to MRI, which is the standard in diagnosis, it can help us in seeing the labral tear like in this photo here, or the condylar damage, or the assess the alpha angle to see whether there is scan deformity or not, and to see the synovial herniation bit. So the MRI is the workhouse for diagnosis of pathologies associated with FI. Okay, and now we usually use the normal MRI. We don't use intra-articular contours, and it shows well all these pathologies. The therapeutic test is still, some patients, when you do everything in examination, you do everything in investigation, you're still not sure what is the source of their pain. Okay, so therapeutic test, in my practice, about 10% of the patient ends up having therapeutic test. Okay, because it helps with clinical decision making in questionable cases. Ideally, it's performed under local anesthetic, and the patient is asked to perform the provocative activity in the first 4 hours following the injection, and the ultrasound guided injection is promising in our clinical practice. Okay. So this patient with FI, usually the diagnosis is somewhat delayed because some other pathologies which are not clear whether it is the problem of the patient or the FI is the problem of the patient. I'm not going thoroughly through the differential diagnosis, but I'm just trying to highlight the concept of the layer concept used in assessment of young adult hip pain. Okay? So the challenge with the young adult hip pain is the complex regional anatomy and biomechanics with overlapping referral pain patterns. And hip pain in young adults is characterized by non-specific symptoms and non-specific imaging studies, and in some times. So what is the layer concept we are speaking about? The layer concept, we stratify the hip into layers. The first layer is the osteochondral layer, meaning that the cartilage, the bone, the inner is the capsule and ribrum. The contractile layer is the muscle. The neuromechanical layer is the nerves and vessels crossing the hip. So, for example, if the patient is having CAM lesion, so this is a lesion at the osteochondral level, he is having excess bone at the hip neck junction anteriorly. This patient will have, as a result of the CAM lesion, a ribral tear, which is an injury in the second layer, which is the inert layer. Okay, and sometimes this put stresses because the patient, when in his physiological movement, has the end of the internal rotation produced at the hip joint, so he tries to have more internal rotation through by his pelvis. He puts more stresses at the symphysis pubis. Some patients will present with osteitis pubis. Okay, together with the labral tear, together with the CAM. So some patients will have this sequence. Okay, have CAM, have labral tear, have as well as osteitis pubis. The understanding of this layers, the understanding of the interrelation between them will help you to reach a full diagnosis of the patient before embarking on treating him. Okay, so in each layer you have different regions, you have different interpretation and interrelation between these layers, and it's very important to be aware of this layer concept because it helps you to properly diagnose and treat the patient. So if you are having just a patient with FI, what the options you are having in treating him? First, you can treat him conservatively with physiotherapy. We are going to speak a bit about this later, and then you can treat him with arthroscopy. Sometimes you can treat him with surgical hip dislocation. My view on surgical hip dislocation in treating this patient, it's a bit of overdoing because you can do with arthroscopy everything you do with the surgical hip dislocation, as well as in the literature, no one except Gans has produced the results of 0% AVN following his technique of surgical hip dislocation. Each surgeon who tried to mimic his technique later on have some incidence of AVN later. So as a patient is having some pain interfering with his daily activity, it's more logic to treat him with arthroscopy because it's a low-risk procedure. It doesn't produce AVN, for example, so the patient will have his problem solved and the risk of AVN is not present there. So the conservative treatment is a personalized hip therapy. The conservative treatment I'm following with my patient is a personalized hip therapy as this being described in the UK fashion trial. It depends mainly on the patient education, prescribing him NSAIDs with individualized progressive exercise programs starting with muscle control, following to stretching and strengthening, with maybe injecting him with steroids, manual therapy, orthotics, and treating existing problems. If the patient fails to have to improve with the conservative treatment, we may proceed to arthroscopy. So arthroscopy has been explained by Dr. Ahmed. We have the two standard portals, the anterolateral portal and the anterior. And here we can do some tear identification. In this, we pass the first instrument in the area of the tear. Okay. Then we pass the loop suture. I usually use the parrot peak. Having my loop, then I do the drilling for the anchor and going for anchor placement. So we use here the Bioraptor. So the Bioraptor suture allow you for tightening the anchor, tightening the loop suture after you put the anchor. And here is the repair, the loop suture attached to the anchor. Okay. And then you do the cam osteoplasty and you make sure by the dynamic test that you have no impingement later on. Okay. And you have this free space as described by Dr. Ahmed. So why looking for the evidence about when to treat and when to do? Why earlier the surgeons have been skeptical about the hip arthroscopy, despite the improvements that has been made about 20 years ago, as has been described by Dr. Ahmed, because there has been history of bad science in relation to hip arthroscopy. Earlier, a small number of surgeons did all the early research, and they tried to find the deformities that they could fix surgically. So the top 8 cited FI articles in the early 10 years was cited by written only by these 5 surgeons. The surgeons believed that bone shapes caused hip pain, and nobody did research to prove or disprove this belief until it was too late. And surgeons used the wrong measurements to determine surgical success. They used angles to measure, they used MRI and images. They didn't use patient-reported outcomes. So the patient-reported outcomes, when it has been introduced, it has modified the practice. So the fashion trial, as has been described by Dr. Ahmed, it's a pragmatic, multi-center, assessor blinded randomized control trial. and it used the international hip outcome tool 33 for 12-month follow-up, and there has been improvement in the arthroscopy group more than the conservative group, and the important thing and the difference was more than the minimal clinically important difference. So for every outcome measure, there is a minimal clinically important difference. So the improvement was there, and this improvement was clinically significant to the patient. As regarding the question when to treat, every patient when he is presenting with phi and labral tear or not should be offered early, initially conservative treatment, every patient, okay? For how long you can treat this patient conservatively. So at this study, they have seen that with increased duration of symptoms associated with worse outcome, but they were looking at about 12 months or more duration of symptoms. In this study, in elite athletes with 98 elite athletes, 49 of them are females, with a mean follow-up of about 18.9 months. They were able to return to sports, but the duration of symptoms has increased. It affected significantly the return to the sport, returning to the same level or not back to the same level or not back to competitive at all, okay? So in another study, it says that with 2 years follow-up, 66 patients with high return of sports with increasing post-operative pre-operative withdrawal time from sport period to surgery, more than 8 months, it is associated with worse outcome. Okay. So what to do? Do we need to do repair for every patient, to do debridement for every patient, to do what we can do? So let us look at the evidence. So in the first study here, the arthroscopic labral repair versus labral debridement in patients with femoroacetabular impingement with minimum of 2.5 years follow-up study, it showed no difference between repair versus debridement. So why we are repairing every patient? Another study showed that labral reattachment in femoroacetabular impingement surgery has been associated with increased 10-year survivorship. Okay. Another study used as adjusted for compounding factor, and it showed no difference in outcome in survivorship of the hip. So the last piece of evidence I'm showing here is a review of the literature and quantitative analysis done by Faris Haddad, the editor-in-chief of British GGS. He said that it seems logical to repair unstable tear in good quality labrum with good potentially to heal in order to potentially preserve its physiological function. This seems logical, despite no little evidence about this. But degenerative labrum, on the other hand, as shown by Dr. Ahmed with long flaps and everything, may be the source of discomfort, and its preservation may result in persistent pain and add the risk of failure of reattachment. So we don't need routinely to fix all labral tears, but it's logic to preserve the labrum if we could. That's the question we are going to ask ourselves here. Is it really hip preserving or not? So initially the paper by Professor Gans showed that the hip the treatment of phi may prevent total hip replacement. This paper, published in 2017, has won the John Charnley Award about redefining the natural history of osteoarthritis. What they have done, they have come to their database, they have seen the patient who had unilateral hip replacement, so that these patients are coming every year to have their follow-up X-ray. And they classified the morphology on the contralateral hip, which didn't have hip replacement yet, and followed up for 10 years. And they classified the morphology for 3 groups. The first group with dysplasia, the second group with normal morphology, the third group with dysplasia, with impingement. So they have seen or have recorded how many patients with dysplastic hips or normal hips or impingement hips will turn to total hip within this retrospective follow-up. They have found that the risk of a normal patient with having unilateral total hip replacement with the contralateral hip having a normal morphology is multiplied by 5 if the patient is having dysplasia, but it's not different if the patient is having impingement morphology. So they see if the patient is having impingement morphology, if you treat him or not, the patient will have no added risk of having total hip replacement. The main problem with this study, despite it having the John Charnley Award, it's not saying if this patient is having labral tears or not, if they are having actually phi or not, because we have agreed in the first, agreed from the start that this is a clinical syndrome. It's not a radiological diagnosis. So this paper shed light that we shouldn't treat every patient who is having thigh morphology as for his abnormal bone shape, because it wouldn't increase the risk of total hip replacement, which is okay. We need to treat the patient who are having symptoms. Okay? The second thing is that we need to consider the hip arthroscopy for treatment of these patients with thigh, not just because whether it's preserving hip or not, but mainly because we need to improve their quality of life in the next coming years. Meaning that, I'm giving another example. If the patient is coming in late 30s, early 40s, having in the knee degenerative meniscal tear, which is interfering with his quality of life and fail conservative treatment, we usually treat it, okay? But we don't look whether this patient will need total knee replacement or not later on. We don't put this in account, okay? So we don't need to consider the hip, just the hip preserving. It may be at will his hip preserving if it has been proved in prospective studies, but is this not the main issue? The main issue, we need to give our patients a better quality of life, and they will be able to return to their activity level and what they love to do. So finally, when to treat, conservative treatment should be offered first for every patient. Earlier intervention may be needed in competitive athletes. What to do? We need to repair if possible. Repair is better in competitive athletes, of course. Neither repair nor debridement has an effect on hip preservation. Thank you very much.
شكرا يا احمد على التوك الجميل ده
الله يخليك يا بيه. الله يخليك.
والالستريتيف. شكرا جزيلا جزيلا.
Very nice.
الله يخليك. احنا معانا دلوقتي دكتور وسيم هيكلمنا عن الابديتس ان diagnosis of periprosthetic joint infection. اتفضل يا دكتور وسيم.
شكرا جزيلا يا احمد. معلش انا جاي في الاخر والناس زمانها تعبانه، فان شاء الله هتبقى concise up to the point. مش عارف كده السكرين واضحه ولا لسه؟
واضحه دكتور وسيم، واضحه كويس جدا.
شكرا جزيلا. انا بس احاول. تمام كده يا جماعه. Thank you very much, my dear professor, to give me the chance to present these presentations. I will go through the updates in the diagnosis of the periprosthetic joint infections. Again, so the diagnosis of the periprosthetic joint infections, which I will tell just the PGI, it's a major, 1 second. It is a major challenging. Why? Because there is no a single test which provide 100% sensitivity and specificity, and to proper diagnose the case, there should be a combination of both clinical findings, starting from the history taking and examination, along with the laboratory findings, including serological test and the synovial fluid test, along with the microbiological cultures with intraoperative findings as well. So I hope by the end of this lecture, we managed to identify a straightforward algorithm to follow to properly diagnose joint infection in a good time. So as we know, the Staph aureus is the most common organism in the PGI infection. Again, there is other low variant organism which may be difficult to diagnose. The incidence of the problem is in the primary joint replacement is between 0.5% to 2%, and the percentage is increased in revision surgery and maybe up to 10%. That's why when we are managing to treat revision surgery, even for non-infection causes, we should be careful. We should to exclude infection. Hopefully, this is the message which I need the audience to know. Every patient who presents with a painful joint arthroplasty should be treated as potentially infected until proved otherwise. This is the message, and this is should be clear in our minds, hopefully, by the end of this lecture. So when I'm going to discuss the diagnosis, I will go through more systematic way, starting from the history up to going through the imaging and tests up to the culture and the new molecular techniques and sanitation if available. History, starting from the risk factor, if the patient is obese, history of diabetes, malnutrition, all this adding to suspicion of the peripheral joint infection. Clinical examination, also the history of where the patient had his first operation, is there any history of poor wound healing, prolonged drainage from the wound, if the patient had any kind of peri-operative or post-operative antibiotics, if the patient had recent infection, recent dental surgeries, any other source of infections to be excluded. And from the clinical examination as well, if there is a clear signs of acute or chronic infection. Acute infection means red, hot, swollen joint. Chronic infection may be a clear sinus discharge from the wound. Going through the investigation, starting with the pen X-ray, again, it's not conclusive, but again, any patients coming to our clinic with the painful joint should routinely have X-ray. It's best to compare this X-ray with which is already on the set, if we have previous X-ray, to compare if there is any new zones of loosening, or is any subsidence of the prosthesis. It's uncommon for the prosthesis to have early signs of loosening in the first 2 years, for example. So just be wary if you find these signs of loosening. So maybe we should sort out infection as a possible cause. Is there any rule for CT or MRI to diagnose infection? The answer is not. Is there any rule for nuclear imaging to diagnose PGI? Again, it's coming with high false positive results, so we couldn't depend on. The role of the serological test, starting from here, please concentrate. So if you have a patient with QED-PGI, starting with ESR-CRP, if the both results come with positive results, yes, you have a test with 95% sensitivity. But again, if it's not 100% infection, and again, if both negative, it might be just false negative. And again, there's 10% of people with negative results have low variance infection. So be cautious, and depending on your clinical examination experience and history taking, again, if you are still concerned about infection, please proceed to the next step. So from the serological testing, what is the new biomarkers now? Apart from ESR-CRP, we have interleukin-6, we have tumor necrosis factor alpha, we have D-dimer, we have procalcitonin. D-dimer now is added to the last well-known algorithm, which I will discuss last thing on the presentation. Joint fluid analysis, which is joint aspiration, which should be done in complete aseptic technique. For who patient who should have aspiration? The answer is, any patient is going to have revision surgery, please do joint aspiration to rule out infection, especially if we're coming with positive high ESR or CRP. Second patient, if the patient has coming with the positive ESR CRP, yes, you should do a joint aspiration to exclude infection. Third one, again, if you are suspicious, if patient presents with painful joint and clinically, even with negative result, if there was a negative ESR CRP and you are suspecting infection, please do joint fluid aspiration, because the results is more or less high sensitive and specific. Second question, if you do aspiration and the tab is dry, are you allowed to inject the saline to come with some fluid to test them? The answer is not, you are not allowed. So you might inject, or might invite infection to the joint. So when you have the aspirate now in your hand, what should you ask for the lab to test? Not just for culture sensitivity. No, the answer is you should send for specific white blood cell count and differential count, including polymorph nucleosides and culture. This is the important. And this is another message, please, when you have aspirate to send, please ask for differential count. Plus the culture as well. So if the synovial fluid white blood cell count is high, this is an excellent, specific and sensitive to infection. So can we ask for extra thing to be done for the joint fluid? Yes. The extra thing you can ask for test cytokines interleukin 6, 8, and 17 with human constructor alpha interferon with the leukocyte esterase and alpha defensin. The reason why I make them bold because it's it is wide common here now in the practice to have alpha defensin even as bedside test. And the synovial biomarker is the synovial CRP. Again, it's added to the final algorithm, which is I will discuss later in the presentation. So leukocyte esterase, the advantage of this test is the easy you can do it. It's just a pregnancy test. Once you have the aspirate, you can test it even inside the operation room, and it's quite cheap if we compare it to the alpha defensin test. And the results come with the either negative or one positive or double positive. If it comes with double positive, it is the result is equivalent to the synovial white blood cell count threshold for diagnosing PGI. So we're speaking about more than 3,000 white blood cells in case of we are dealing with per mil, if in case we are dealing with the chronic infection. The limitation, if these aspirate come with the blood-stained aspirate fluid and you test it, the results may be not reliable. And on the other hand, if we are dealing with the alpha defensin test, and which is the alpha defensin, which is a peptide secreted by the neutrophils to fight infection, the advantage is it is not affected if the aspirate is blood-stained, not affected with the antibiotic therapy, and come with high sensitivity and specificity as well. And there is a recent paper, if the patient have a positive alpha defensin test, again, it's not 100% specific. So there's about 5% of patients come with positive result and it's false positive. So if you did for this group of patient synovial CRP as well, it will exclude it will identify the truly positive from the false positive patients. Again, so the alpha defensin is the best bedside test, but it is quite expensive. So we moved from the pre-operative management to the intraoperative ways to diagnose infection. Now we are inside the table, inside the operation room and on table, and now we open the joint and we manage to take samples. There is a possibility to do a frozen section if the facility has this technique available. It's become positive if we can find more than 5 polymorph per high power field in 5 high power field in 400 magnifications. Again, it's come with the low sensitivity because you might miss the area of infection, and you should have a well-experienced pathologist available to diagnose positive results. But again, if it's positive, it's considered one of the minor criteria, which I'm going to discuss later. And going to the tissue culture, which is the gold standard to diagnose what is the organism. But there's some tips and tricks. So you should at least have 5 samples taken from different tissue layers to be taken most preferably from the visible inflamed tissue and from the interface between the prosthesis and the host bone. Try to make it odd number, so not 5 is better, not 6, not 4, and is there any rule for culture swab to diagnose infection? No, because this usually come with the false positive results or non-pathogenic organism. And is there any rule for bone culture to diagnose infection? In the international consensus meeting, which was held in 2018, the answer was inconclusive. So now we have culture, and I'm sorry, there is it's reported, there is no 100%. So if there is a report, the report in literature, even if you have culture, there is a 5 to 42% of patients present with culture negative infections. So how we should treat them, or how should we manage? So some tips to decrease the rate of culture negative infection. First thing, we should withhold antibiotic before samples, at least prefer to be more than 14 days. And we should send the culture not in the same, in an test tube, should be sent in pediatric blood culture bottles. And we can ask for extended incubation period. Again, if we do all this measure and the culture come with negative results, so we can do sample again, or we can wait for a longer incubation period, or we can go for further new molecular techniques or sonication if available. So regarding the molecular techniques, it's based on amplification of the bacterial genome, either RNA or DNA. So the PCR technique amplifies the bacteria RNA, and the next generation sequencing is amplifying the bacterial DNA. And the advantage is the rule of them is to diagnose the culture negative results. So is it advisable to do the molecular techniques for all the specimens? The answer is not, because it might come with the high false positive. So it's the rule of the molecular technique test is in the case of culture negative BGI. So sonication is a method to dislodge the bacteria from the biofilm, from the prosthetic component when we are doing the first stage revision, for example, and take the infected component out of the patient. So we put it in the sonication path with the ultrasound waves energy, which dislodge the bacteria from the biofilm. Then we take this fluid for culture, and the yielding rate is much higher than the culture itself from the tissue patient, and the incubation time is much less as well. So to sum up, this is the cutoff threshold biomarker values for diagnosis BGI, either acute or chronic situations, including the serum biomarkers and synovial biomarkers. And going to the algorithm, so before 2011, there was no known algorithm to diagnose infection, and it mostly was done by just experience. The Musculoskeletal Infection Society 2011 provide a first known criteria to diagnose in PGI, and it is revisited and accepted with International Consensus Meeting 2013, and divided the criteria in two major criteria. If you found and minor criteria, if you found one of these two major criteria, the patient is having PGI, chronic PGI, sinus tract communicating with PGI with the component, so it is a chronic PGI. Two positive culture of the same organism, so two positive with one organism from the affected joint. If yes, so the patient has PGI. The minor criteria, these are 5 minor criteria. Any 3 of the 5 the patient come is PGI. The minor criteria is a high ESR CRP, high synovial white blood cell count, high synovial neutrophil percentage, and if we have isolated one organism in one culture, or if we have 5 neutrophils per hyperfield in 5 hyperfields in 400 magnification. So if we have 3 of them, so the patient is diagnosed positive. If we have one of the 2 previous major criteria, the patient is positive. So this is approved 2013, and since between 2013 and 2018, there was a merging in the new biomarkers, including serum biomarkers and synovial biomarkers, including leukocyte esterase, alpha defensin, CRP, and molecular studies as well. So they tried to include all the new weighted biomarkers into a more algorithmic way, and is have discussed in the International Consensus Meeting Philadelphia 2018. And they tried to find evidence-based weight-adjusted algorithm to diagnose infection, and the create this scoring system, which is in major criteria there is no change. 2 positive culture, same organism is infected, sinus tract is infected. Going to the minor criteria, where they did a scoring system, and they added new serum or new biomarkers. So the minor criteria with the scoring system here, they added serum D-dimers to CRP or ESR, and they added leukocyte esterase, which can be done on lab or can be done as bed-sized test in the same weight of the positive synovial white blood cell count and POSE score 3. And they added a positive alpha defensin test, which was not present in the previous MSI's criteria. And also they added elevated synovial CRP. And beside each one, they give a score. And depending on the final score, if above 6 is infected, between 2 and 5 is possibly infected. So this where we can go for the next table, which is going for intraoperative findings, including positive histology, purulence, and single positive culture. And again, each one is scored. And again, if the final score is between 4 and 5, this is where we can do the molecular test or syndication. So it is not difficult. It is easy way to diagnose infection. And it is now through a mobile app, through Android or Mac. So we just answer the questions, and you will have the score, and you will have the diagnosis at the end. So take-home messages. When you are dealing with patient with painful joint, please, you need to exclude infection. And serological CRP test is a useful screening modality, especially when you are dealing with the primary joint, and you should or you must do it before doing revision surgery, even for a non-infected cause of revisions. And it's better to follow the algorithm. Thank you.
ثانك يو دكتور وسيم. محاضرة شيقة وممتعة وكلنا استفدنا منها. دلوقتي يا دكتور أحمد بقولي في سؤال لحضرتك كلية، هو في اللي هو please elaborate on the results of arthroscopic shaving of cam lesion in SOFI and the relation to the grade of slip.
اتفضل يا أحمد.
اتفضل.
Regarding the SOFI arthroscopic hip arthroscopy for slipped upper capital femoral epiphysis, the problem with the slipped capital femoral epiphysis, there are a few issues. If we're talking about the healed one, so the acute one, we know the treatment is quite different, but the healed one, which the patient had slipped capital femoral epiphysis in the past, and then we need to treat the sequelae. So this one we're talking about. So for the healed one, the problem is the deformity has a few things. Deformity, they have cam, and they can have labral tear as a result of the cam. That's the easiest part. But also the problem is they do have retroversion. So the proximal femur or the head of the femur is retroverted compared to the femur, because if you think about the SOFI, the femoral head stays in the acetabulum. The proximal femur moves forward, so the plane of the femur is now in the front, and the head of the femur is backwards, so it's retroverted. as well as there is varus of the neck and short neck as well. So lots of things. And there is shortening of the leg. So they have shorter leg. It's about centimeter or two, depends on the degree of the slip. So if you have the whole form, the varus, the retrovirgin, the labral tear, the cam, and the short leg, I don't think that hyperarthroscopy could manage the whole lot. So you can't do the hyperarthroscopy. You can do the hyperarthroscopy, but you won't be able to manage the whole lot. However, in mild slippage, the femoral retroversion is a little bit. They don't have much shortening. So each of those deformities are mild. So in mild slippage, you can still do hyperarthroscopy, manage the cam, manage the labrum, provided they don't have acetabular dysplasia, right? If they did have the SUFI early on, when they are young, really young, 12 or 13 or something, not 14, 15, then these patients might have a little bit or more acetabular dysplasia because the femur is not, well, it's contained, but the shape of the femur is deformed. Then the acetabulum will be deformed, compensatory deformity, because this happened before the healing of the trioidrate cartilage. If you perform hyperarthroscopy when in slipped capitofemoral epiphysis with mild deformity, and they do have acetabular dysplasia, they can get worse after hyperarthroscopy. However, if you do have a mild slip angle, which is healed with no residual acetabular dysplasia, and you just have some cam as well as labral tear, I think in those cases you can manage arthroscopy. If you do have the whole lot with the retrovirgin, varus, shortening, the ideal would be femoral osteotomy, open hip surgery. The femoral osteotomy would be either to do the triplane osteotomy, so you do derotation, valgus osteotomy, mainly derotation and valgus osteotomy. That's the two main thing, and this will lengthen the leg. This will correct the varus, but in the same time you derotate as well. This will correct the derotation as well as open removal of the cam. I think that's the best treatment for the cases of SUFI, but this is also associated with maybe a degree of AVN also. So the other option is just to do derotation and open cam osteochondroplasty for the severe and moderate SUFI. For the mild SUFI with no dysplasia, I think you can treat arthroscopically. A very good question. Thank you.
شكرا دكتور احمد على الاجابه الكومبريهنسيف ديت. اكيد بتفق مع حضرتك ان هي المايلد ليجن اللي هي بتتعالج بالارثروسكوبي، حاجات ثانيه بتحتاج مور كومبلكس بروسيجر عشان ادرس البروبلمز كلها. شكرا جزيلا. واحنا كده مفيش اسئله ثانيه معانا. اعتقد ان احنا خلاص كده بنكونكلود الساينتفك ميتنج النهارده. شكرا جزيلا لكل السبيكر. شكرا دكتور احمد، شكرا دكتور وسيم،
شكرا الناس كلها.
شكرا جزيلا.
شكرا دكتور عادل ودكتور عبد الله، متشكرين جدا جدا، ومعلش سهرناكم يعني النهارده.
شكرا يا بقولي، شكرا يا وسيم. ربنا يحفظكم يا رب، وان شاء الله نشوفكم على خير باذن الله.
شكرا دكتور عادل، متشكرين. بروجرام ممتاز، ودكتور احمد فؤاد ودكتور عبد الله يعني عاملين شغل عالي. شكرا جزيلا جدا.
ربنا يوفقكم. شكرا جزيلا.
نشوفك على خير.
شكرا دكتور عبد الله، شكرا دكتور احمد، شكرا موصول دكتور وعاطف، واشوفكم على خير ان شاء الله.
تصبحوا على خير يا جماعه. شكرا جزيلا.
شكرا دكتور وسيم، تصبحوا على خير.
تصبحوا على خير. مع السلامه.
الله يسلمك.